CataractCoach.com, podcast series, episode number 100 with Dr. Pradeep Prasad, the new host of RetinaRounds.com. Now, I love Cataract Coach, but I also love retina surgery. When I was a first-year resident, I thought, you know what? I'm going to do retina surgery. And I was very excited about it. But at the time, remember, there was no anti-VEGF, there was no OCT machine, and they thought the treatment of macular degeneration was macular translocation surgery, which wasn't the best idea. But now, retina is a very different world. Retina is amazing. I love retina. But I don't have the expertise there. So I said, I want to have a retinal channel. Now, we love alliteration, so we've got CataractCoach.com, but now we've got RetinaRounds.com. And our new host is Dr. Pradeep Prasad. Now, I have known Pradeep since he was a medical student, and then since he was a resident and a fellow. He was amazing. Like, I wish I was a resident at the same level that he was a resident. And when he was a retina fellow, unbelievable. On top of that, Pradeep has also done an MBA, a Master of Business Administration at UCLA, mid-career, while he's a professor. The amazing people are so good that the university never lets them leave. So when Pradeep was a med student, they were like, no, you're going to do residency right here. And he finished residency and they said, no, you're going to do fellowship right here. And they kept him for fellowship. And they said, no, you're done with your fellowship, but you're going to take your first job right here. Don't leave. And he has been at UCLA in retina for many, many years. He's been chief of one of the big county hospitals, bigger than the hospital I was at, which is Harbor UCLA for Pradeep, Olive UCLA for me. And Pradeep is also now running the entire retina fellowship at UCLA. He's an amazing surgeon. Like, if I have an attachment, I'm calling him like right now. So he is that good. But he's also an incredible educator. And you're going to love learning from him. So I encourage you, sign up for the RetinaRounds.com daily email. He's going to have a podcast too. He has an MBA. He's going to talk to us about the business of ophthalmology on a much more amazing level than anyone else can ever do. I think you're going to love it. Anyway, check out this podcast. And remember, go to RetinaRounds.com, sign up for the daily email. And of course, we're also going to have a daily video for Retina Rounds on YouTube. Links are below. Check it out. Anyway, Pradeep, let's do it, buddy. Welcome back to our Cataract Coach podcast. Today, I've got a very, 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 very special guest. Someone I've known for, don't tell anyone, 20 years. And the new host of our RetinaRounds.com channel, Dr. Pradeep Prasad. Pradeep, welcome to the channel for Cataract Coach.
Thanks so much for having me, Uday. It's great to be here.
And of course, this is also episode number 100. This is my 100th podcast episode, so I've finally gotten pretty reasonable at doing this.
It's incredible.
And an honor to have you here. Now, for our audience, just tell us about what's your path in ophthalmology. So I knew you as a resident. You were a resident, maybe, I don't even know how many years, 15, 18 years ago?
Yeah, about 15 years ago.
And you were such a fantastic resident that you said you wanted to do retina. They were like, oh, you're staying here, buddy. You're not going anywhere. We want you to stay. And then you were such a great retina fellow. And UCLA Retina was very busy at the time. You worked super hard. They said, by the way, you're staying here for your job. And then they hired you as professor. You went up the ranks. Tell me your whole path.
Yeah, it all started, I was a UCLA medical student, actually. And so our first time that we met was when I was a medical student. I
hope that was nice.
You were very nice, very nice. Maybe a touch intimidating by your knowledge, but very nice. And it was the people that really I wasn't even thinking about ophthalmology when I was thinking about what path I was going to take in medicine. Certainly didn't come to medical school thinking I was going to become an ophthalmologist. And it was the people, honestly. I did the rotation. It was part of the surgical elective rotation. And I fell in love with the people. I fell in love with, of course, the field, the diseases, the impact that we have. All the same reasons that I think all of us in ophthalmology were just drawn to it. And of course, there's the tech component to it too. I mean, it's just such a innovative field in many ways, not just on the medical side, but just the paths that people can take within our specialty. So I was drawn to it from the beginning and from the beginning of that rotation. And fortunately, it wasn't too late for me to pivot into ophthalmology, and I was lucky enough to stay as a resident. And through my residency, I had a chance to work with amazing mentors. You among them. And although I didn't go into cataract surgery or general ophthalmology, I feel like a lot of the teachings that I got from you and from other faculty members, those stick with me as a surgeon. Fundamental things. Obviously, your cataract coach is all about surgical videos. Well, the first person to ever stress to me the importance of recording videos was you. And that's had a huge impact on my career, my ability to grow as a surgeon. And that's what I also have tried to impart on my trainees, on the residents and fellows that I've had a chance to work with. So it's been huge. I've really great faculty at UCLA that I was able to learn from as a fellow, and they're my friends and colleagues, and it's just been a great path. So yeah, I finished fellowship, and I was lucky enough to be recruited to stay at UCLA, and haven't looked back ever since. In fact, my first position was sort of the brother position to your former position as chief of ophthalmology at all of you. I was a chief of ophthalmology at Harbor. So for those who aren't familiar with the county system or LA in general, all of you sits about 30 minutes to the north of UCLA, and Harbor is about 30 minutes to the south of UCLA. Both county hospitals, safety net hospitals, so very similar patient populations. And I would say that was like my fellowship after fellowship. I learned so much being at the county hospital, because the type of the first of all, the patients are wonderful. They're just the sweetest people. They're so grateful. I mean, it's just like you really feel like the reason that we went into medicine in the first place, to help people. You really get a sense of that in the county system. And beyond that, you see some of the most just the rarest of birds come through the door every single day. And so that really helped me to grow a lot as a clinician, but primarily as a surgeon. I mean, the surgical demands at the county hospital are really parallel to none. And so I learned a lot going along the way. I hope I was able to teach along the way. I don't have quite as many teaching awards as you do in the back there, but but just had a fantastic time. Did that for about 10 years, and then just transitioned to being full-time, at the main campus. So just really learned a lot along the way, and had a few twists here and there too. I ended up going to graduate school during.
We'll talk about all that. Don't worry.
Yeah.
Yeah. So for those who don't know, because we have a large international listenership too to our podcast. In Los Angeles, very, very big city, and there's only basically 2 medical schools in Los Angeles County, maybe 2 big universities, UCLA, USC, and there are basically 3 large county hospitals, which are like safety net hospitals. Patients who are really bad disease, can't afford to pay, or whoever walks in the door will treat them, no problem. And so for UCLA, they were controlled 2 of those hospitals. One was, north of Los Angeles, all of UCLA, where I was chief of ophthalmology, and then south was you were my counterpart at Harbor UCLA, which is even a bigger hospital than where I was, and busy. And these are the patients, like you were saying, it's an unparalleled experience, because these are patients where the first time they're seeing an ophthalmologist, they present with neovascular glaucoma, proliferative diabetic retinopathy. There's a little vitreous hemorrhage too. There's macular edema, and now they need everything at once. And so there were so many patients where, even though you're a retina specialist, I mean, how many patients did you do? Even I did. Ahmed valve, put the Avastin in, do the indirect PRP while they're on the table, obviously make them pseudophakic in the same sitting. I mean, these were just really incredibly difficult cases, like I've never seen again in private practice.
No question. I mean, there's really nothing like it. And it's, gosh, on the one hand, it breaks my heart that patients are presenting to us at these very late stages of disease. And our group, you and I together have worked on trying to improve access and get to patients earlier, and try to change the trajectory of their disease so that they don't present with such advanced pathology. But by the same token, it's a tremendous responsibility and a tremendous learning opportunity. And so for our trainees who are able to work in that environment, that's why I think the residents who come through our department, they really leave with such a tremendous skill set that's unrivaled, because they're just expected to do so much, and they're given the opportunity to do so much. And you and I both know, it's yes, we're in a safety net hospital, but our expectations for outcomes for patients doesn't change because we
Absolutely.
are at one facility versus another. We want
Right.
the very, very best, and we always try to advocate for the best equipment, technology, and of course we want the best doctors too to be able to take care of these patients. So, no, it's a tremendous experience for the better part of a decade.
I remember when I made sure we ordered at our county hospital a new microscope with built-in OCT. And at the time, even the fancy neighborhood of UCLA and Beverly Hills, no one had this. But we had it at the county facility, and we used it that's why I had so many videos of how to make your phaco incision, because you do the incision, and I do an OCT of the cornea insert, here's your incision. And then obviously I taught the residents lamellar transplantation for the cornea. Obviously the OCT was great if you want to look at the retina, but it became a really useful device. And now obviously we have it in many more locations. But yeah, you're right. Those patients got absolutely cutting edge. And then I also always wanted to deliver the same care that I want to receive. So even if it's a county patient, no, we have to sweat the IOL calcs. Let me see. I want to hit plano. Well, where's the steep axis? Why don't we make an incision there? No, you know what? For this patient, let's go ahead and order that toric IOL. And so you're really giving the highest possible level of care to these patients. And the best part is, as you said, they were so sweet. Oh my gosh, so thankful. I miss that every day. I tell you.
I do, and it's a whole team of people. I mean, you had the nurses, the whole staff at all of you, everybody, and the same is true at Harbor. I mean, our techs, our nursing staff, are the people who we got to work with in the OR. They all came with the same passion, the same mission of trying to deliver the highest quality care. And so it's a really special environment where you don't feel like you're on an island. You've got a lot of people in there, partners with you, that try to work towards the same goal.
Yeah, and you also mentioned people. We've had some of the same mentors. When I was a first-year resident, 1997, I was learning how to spell ophthalmology and figuring out how to turn on the slit lamp. And I did as a first-year resident, knowing very little, in the clinic of a very famous retina surgeon at the time, who was my professor, Stephen Schwartz. And he pulled me aside at the end of the day. He says, "You're good, but you're better than that." He says, "You better be the top resident in your class, no matter what. Everything." And you know what? He held me to a higher standard, and I stepped up. And to this day, I appreciate that.
No, I see a lot of similarities between you and Steve Schwartz, as you mentioned it, because he was my mentor, and I continue to learn a tremendous amount from him, and he always expected the very best.
Right.
It was 150% effort. It wasn't 100% effort, and you were the same way. So no, I totally see that. I can see how he rubbed off on you a little bit.
Yeah, he was amazing. And then another great mentor for you, which I didn't obviously go into retina. I disappointed some people. I liked cataracts too much. Buzz Krieger, or Alan Krieger was the name, but he went by Buzz. What an amazing individual. Tell me the impact that Buzz Krieger had on you and your career, and even just your philosophy of life. An amazing man.
Look, he had a profound impact on an entire generation, multiple generations of retina specialists. He was just the most beloved person at the Stein Eye Institute that I ever came across with, and he was more to me than just somebody a surgical mentor or a clinical mentor. I mean, his approach to life was always, first of all, his approach to medicine was always the patient first. Mm-hmm. And I learned a tremendous amount surgically from him. Don't get me wrong. One of the most talented surgeons that I've ever had a chance to work with. But actually what he taught me more than anything was just how to sit next to a patient, how to put them at ease, how to explain very complicated concepts that we spent years trying to learn. and distill that into a way that makes sense to patients. And building, there's just nobody who could compare with him. I mean, there's nobody in terms of how he was able to put his patients at ease. He was able to build confidence, and I've fortunately been able to take over a lot of his patients and continue to care for them. And so many of every single one of his patients, they just are effusive in their feelings towards Buzz. It was a huge loss when he passed, but what's great about being in academics, teaching, and there's all sorts of different ways to teach, and I'm sure we'll talk about that soon, but the impact that you can have, not just on the patient who you're taking care of, but also the other doctors who are going to then take care of those patients, and then they're going to pass it on to somebody else. I mean, that sort of butterfly effect almost is really, I think, what draws us to medical education in general, is because we can have a really huge impact on the care of patients beyond just those patients that we have a chance to take care of ourselves.
Totally agree. In fact, one of the reasons I really had to recruit you to do RetinaRounds for us is you're just a natural born teacher. You obviously have taught medical students and residents and fellows, directing the residents, the Retina Fellowship program there. Very beloved teacher, and you're just naturally good at it. And I think transitioning to video, the amazing part is my reach is even greater. For those who don't know, I stopped teaching residents a couple years ago, and now I teach the world, basically. I lectured in 21 countries last year. And the CataractCoach videos are 1 million views a month now across all channels. So, I mean, the ability to teach worldwide is just staggering.
It really is. It's that scale that's the difference, right? I mean, so we go into medicine because we want to take care of the person, the patient in front of us, and then some of us will go into academics because we want to teach and change, train that next generation. But what's really unique about, I think, what we can do in ophthalmology, because it's so visual based and video based, is that we can actually have an even larger scale impact on the care of patients worldwide, as you said, and that's what's really drawn me to it. Video teaching is not new to us in retina, and certainly not new to UCLA Retina. We've been doing this. We were doing these in person since I was a resident, and we have great recording equipment in our operating rooms now. And so instead of just describing the surgeries, we transitioned to just watching the videos. And you'd have multiple faculty members who would give their opinions. You have a room of 6 or 7 different people. You get 6 or 7 different opinions. Right. And that, for me, when I was a fellow, and what I've heard from our fellows who have since graduated, that's really the best part of learning. I mean, you can learn surgery. You can learn to do surgery in a variety of ways, right? You can practice in the wet lab. You can practice, virtually. That's not the same as actually doing. Of course, that's the best way to learn, is to actually get your hands dirty, so to speak, and. But being able to then go back, right, and you yourself look at your own video, be your own critic, and then to get the opinions of a few other people who you really respect, that then takes you just to this new level, right? And so this is something that we've been doing every Friday. Actually, every week we dedicate an hour and a half just to look at surgical videos together and to share opinions. And I learned from my colleagues and vice versa. And so that's what I hope that we can achieve. I'm sure we can, through this platform. And you've demonstrated it already. So I hope to sort of follow along in those footsteps.
There is a lot to be learned from the crowdsourced data. The neat part here is, you want peer review. I'll tell you real peer review. I'll put a video up and I'll get 10,000 ophthalmologists seeing in the first week. And you can get as many comments as you want. In fact, I did something very sneaky, I got to tell you. In January, in fact, I got the notes here. On Saturday, January 25th, video number 2455, I posted it as "An anonymous surgeon wants your feedback." And I showed a video of me operating. I didn't tell anyone. Now people know, because this podcast is airing now end of February. But about a month ago, I put a video up and I said, I want all your feedback. Please be as honest as you can. And I didn't tell anyone it was me. And that's very helpful. I want to know.
For sure. And, think about it, like from a retina perspective, we're so subspecialized, right? In
Right.
ophthalmology, we have all sorts of different subspecialties. And then even within retina, there are some people who, sort of do bread and butter, puckers, holes, retinal detachments, diabetic vitrectomies, et cetera. There are others who really focus on oncologic diseases of the eye.
Right.
There are people who specialize in trauma, and so on and so forth. Isn't it so neat to be able to post a video and then get the feedback of a guest professor
Yeah.
on video, right? I mean, we have access now through technology to get the opinions and feedback of the world's experts throughout the world in our field. And so that's sort of another dimension here, right? It's not just showing videos of our trainees and our own videos and what we've learned from that, sort of distilling it down into maybe one or two key teaching points, but also to be able to take videos and say, let's say, Dean, you're an amazing trauma surgeon. What do you think about the way that I approach this case?
Yeah.
Right?
Yeah. Right.
And so that's the kind of thing that's a sort of another layer that we can do through a platform like this that just wouldn't be possible at an individual academic institution.
Right. The group learning is amazing. In fact, I learn so much from doing the CataractCoach videos because I get videos submitted to me, 30 to 50 videos a week. I go through every one of them. And there are some things like, wow, that's really clever. I never even thought of that. And those are like, I've got to post for sure so that we can teach the world about them. I mean, the amount of learning and the beauty is 5 minutes a day or less. And you get to learn so much. In a year, watch these videos, you'll become a much better surgeon. The other thing you brought up was very interesting is, obviously we specialize in these ultra tiny subspecialties of ophthalmology. I had a friend who sent me a patient and I said, oh, I don't actually do that part of ophthalmology. That was some retina patient. And he's like, wait a minute, you tell me eyeballs, 2 things the size of walnuts. You don't do the whole eyeball? I'm like, actually, I don't. So for lay people, and actually he's an MD, he's an internist. He was just like, you don't do the whole eyeball. I'm like, no, I just do part of it. But the importance is we have to know all this. Like I have a strong interest in learning the retina stuff because that patient who comes in and if I don't pick up that ERM ahead of time, now you got macular edema post-op. If I don't pick out some other disease, I've got to examine the retina as well. I got to know the whole eye still.
Absolutely, and vice versa, right? I mean, there are times when if I'm doing a secondary lens, there are things that I have learned from CataractCoach that I never learned in retina fellowship. I know how to do the surgery, of course, but how do you get the best outcome visual outcome for patient in that particular example? Well, that's something where we can learn from each other. So that's definitely something. I hope that this is not just going to be for retina specialists, certainly geared towards retina specialists, but that there will be educational value for everybody in ophthalmology.
Oh, absolutely. Because I was picking your brains earlier, but like, what's the actual retinal detachment risk for these high myopes we're operating on? When I get that patient with an axon like the 28 or 30, who's let's say 60 years old, and I make them pseudophakic and take out that 4.5 millimeter thick crystalline lens and put in that really thin IOL, that vitreous shift. What are the long-term actual risks? So I think there's a huge interest because, especially worldwide, cataract surgeons don't just do cataracts. They do all of ophthalmology, and they have to also know retina, posterior segment as well as anterior segment.
Absolutely. I mean, so to the extent that a cataract surgeon, the next time that they're operating on a -12 myope, they say, you know what? I'm not really great with scleral depression. I think I'm just going to send this patient to my retina colleague and get a proper examination done. If anything needs to be lasered in advance, we can take care of it rather than dealing with it after the fact. That's a huge benefit, to everyone involved.
Yeah, like the patients I send you, these ultra high myopes, get your blessing ahead of time. I call it share the love and the liability with your retina colleagues. But it's so helpful to me. And then you obviously, once the patient's pseudophakic, a month or two later, go back to see as the vitreous shifted around with the thin IOL in place, has there been more traction on the retinal periphery? Absolutely.
Right. And look, and you've had a number of great videos on anterior vitrectomy, different approaches for anterior vitrectomy, even going through a pars plana approach. Well, I think having a retina surgeon's perspective on how to position the vitrector, right?
Right.
What's safe, what's not safe, I
Right.
think can go a long way to for those surgeons who are doing limited vitrectomy for certain patients, how can they do that in the best possible way? And so this platform will allow them to do that.
Well, even simple things too, like when you have that patient where you do a cataract surgery, the capsule ruptures, you do a little bit of limited anterior vitrectomy. In the post-op period, please, you gotta check the retinal periphery. You gotta dilate them up. You gotta do a depressed exam.
Absolutely, and even better, send them to a retina specialist so
Yeah.
that as you said, I mean, look, we all have our areas of expertise, and for the, more than the liability, obviously, liability is something that people care about, but for the benefit of the patient, like just get the best. They've had an unexpected outcome. Let's just
Right.
give them the best possible care going forward, so that we can mitigate any risks going forward. That's really the goal.
Right, because sometimes we don't realize until I point it out. Like I like to point out in my videos, when the capsule breaks, your cystoid macular edema rate is now 10x. Your endophthalmitis rate is 10x. Your retinal detachment rate is 10x. I mean, this is that's a lot of X.
And time is of great value there, right? So if we can catch it early, the outcome is completely different than somebody who's been sitting around for days or maybe longer. So
Yeah, very, 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 very true. Yeah, I think there's so much overlap. I think the RetinaRounds channel is going to be super popular among our viewers on Cataract Coach, because just to learn these things, there's just so much important information. Now, so much so that what's happened recently in the last many years, let's say 5-10 years, this medical retina fellowships have become super popular. Like when I was a resident, call me old, I finished my residency in 2000, so 20, oh my gosh, 5 years ago. Oh my gosh, 25 years ago. There was no such thing. No one did a medical retina fellowship. But slowly it's become more and more popular. And I think maybe that's a good thing. That's like maybe people just like cataracts, but they want to just know more about the retina, right?
yeah, I mean, look, the way that we manage retinal diseases on a medical basis, I mean, surgically, certainly things have changed, but gosh, we didn't have anti-VEGF, 15 years ago, right? Not really, it's so the proliferation of therapeutic options that don't involve surgery has grown, and we're now extending into a variety of inherited diseases and other areas that are, I think, it's its own field, right? So, like for example, my colleague, who many of your viewers probably have heard speak before, David Saraf, his level of knowledge. We both manage patients with age-related macular degeneration, but his level of knowledge of age-related macular degeneration is so much greater than 99% of retina specialists, right?
Yeah.
And so there's just so much more to know. There's more imaging now, and so there's a lot of nuances to disease. There's a lot of therapeutic options, and so that's where I think you're seeing it grow as a subspecialty. There's certainly a lot of demand too. I mean, think about how many injections are done every day. There's not enough vitreoretinal surgeons to do all the injections that are needed. And so having medical retina colleagues who can help with that certainly is a tremendous benefit to the retina community and patients.
Yeah, I mean, and the numbers are like in the US, 4 million cataracts a year, but like more than 10 million individual injections a year, like crazy numbers.
Right.
You think we'll get to the point like in the UK where it's actually nurses who do the individual injections? In the US, it's still physicians.
That's a good question. Whether it's nurses or physician assistants or maybe even, it's certainly there are general ophthalmologists who do intravitreal injections.
Sure.
I don't know. I don't know the answer to that. I mean,
Yeah.
it's a complicated question. There's a lot of political nuance to answer that
Sure.
question. But I think where the field is moving, as I'm sure you're aware, is that we're looking more and more towards addressing the injection burden, whether that's through medications that have greater durability in the eye, or other therapeutic options like gene therapy and other ways. There's a port delivery system, for example, a lot of different ways to be able to deliver drug for a longer period of time, just to decrease the number of times that a patient's having to come in. That's good for the patients. That certainly helps to decompress the clinics so that we can see more patients and help more people. So that's where I think the field is going. I don't know if we're going to see the injection clinics being handed over to non-ophthalmologists. I think there's a lot of value actually in keeping it within, within our specialty, because look, we've gone to school for a number of years to learn about the eye and the pathology of the eye and the anatomy of the eye. And for 99.9% of patients, or even 99% of patients, it's fine. It's all the same. But just for that 1% of patients, that could mean the difference between a retinal detachment and not, or endophthalmitis or not. And those aren't small things. We can fix retinal detachments, we can cure endophthalmitis, but the outcome after that is highly variable. And sometimes it's great and sometimes it's not. So really, our responsibility is to do what's right by the patient. That's our number one goal. And so if we're facing a crunch because the numbers are just not there, I wouldn't sacrifice safety, patient safety for that. I think that and that's really where our field is going, is that we're trying to find new technologies, new strategies for dealing with the volume issue as we're facing it now.
Well, it's what Buzz Krieger taught, which is patient first. Right. What's best for the patient? Always put the patient first. And that's
absolutely,
important lesson. Yeah, I mean, how much our field has changed too. You were saying before, 15 years ago, there was no anti-VEGF. In fact, when I first started in cataract surgery, I examined retinas without an OCT machine. But now I just think 100% of patients I do cataract surgery on, I get an OCT scan of the macula.
Absolutely. No, it's tremendous, and where we will be 10 years from now. I mean, it's exciting actually. That's what makes our field so really. I mean, look, we're biased. It's the greatest field in medicine. I think you and most people in our field would agree, because the speed of innovation is so great, and people are innovating in all sorts of different arenas, right? It doesn't always have to be through basic science research. There can be innovation on the technology side. I mean, one of our friends and colleagues is developing. You had a great video on this. Is a surgical robot, right? Yeah. That's being developed in the private sector. So look, there's all sorts of innovations that are happening in all walks of our field, and that's what makes this where we will be in 10 years, 15 years, is very exciting to me. And really on the medical education side, medical education doesn't end at the end of residency or fellowship, right? It's lifelong learning, and platforms like this, I think, really, I think these types of platforms allow physicians who are maybe 5, 10 or more years out from training to still stay up to date. So they have all the benefits of teaching from a fellowship, but they're obviously done with training. So, but the learning never ends.
Yeah, you're absolutely right. In fact, our field keeps evolving. The way I operate today has nothing in common with the way I learned to operate 25 years ago. And in fact, we've done demographic analysis of our videos and see who's watching. Especially with YouTube, I can get great data. It's not just young surgeons. It's actually 50% of views are from surgeons who are age 50 or older. 50.
Right.
So it is a pretty even distribution. Half more viewers are under age 50, half are over. And these videos, even if I put a video of like, here's an eval, I do an eval of like a resident cataract case number 100, that'll still be watched by surgeons who are well into their practice. I mean, 10, 20, 30 years into practice, because there's still some nuances to be learned, always.
Yeah, it's funny. I always kind of viewed your Cataract Coach as a platform as kind of like the daily ophthalmologist meditation, right? Like you might like spend like 5 minutes of wellness every morning just to kind of get your mind, your brain in the right frame of mind to tackle the day. And I kind of feel like Cataract Coach is sort of the same thing, right? I mean, professionally getting your mind in the right frame of mind. And so even though, maybe a resident who's operating, there's still value in that. Maybe you learn something from that particular case, but also just kind of getting your mind in the right, getting yourself in the right frame of mind to tackle your surgical cases for the day.
In fact, it's so funny you mentioned that. Usually evenings before my next surgery day. So my big day is Monday. So Sunday nights, I tend to kind of just chill out, play on the iPad, and I tend to watch surgical videos. Just to get in the mood. And then from all different kind of videos, or we have a tough case coming up. Like, you know what? Let me watch a video about. Let me see how other people approach that tough case. And that's the beauty of what we're doing now. Like anywhere on the planet, you can get that your phone and watch a video in high def on demand. It's so
Right.
wild. But in
Right.
fact, I actually want RetinaRounds.com for a reason. Because I need to like catch up on my retina learning. I need 5 minutes a day of like give me 5 minutes a day of retina so I can like, get a little bit deeper into my knowledge there because it's been a while.
Yeah, no, I mean, I think a lot of people are in the same boat. I don't do cataract surgery routinely. Every once in a while I'll have to, but for the most part, I hand that over to my cataract surgery colleagues. But I still love watching the videos. It's fun. It's fun.
Yeah.
I mean, look, we went into the field because we like to operate. We like to be in the operating room, and
Right.
whether it's our case or somebody else's, in a different discipline, it's still fun to watch. And there's always something to learn, even if it's not exactly the same field that you're in.
Right, for sure. Or just to see how people approach it differently. As you said before, like you'd have the rounds when you were a fellow or even a young faculty member, and then they're asking, okay, different faculty members, well, how would you approach this case? What would you do here differently? And there's just so much to be learned by that. It's such an incredible format. And yeah, video makes it really easy.
Right. Yeah, I mean, look, our ability to connect and communicate today is very different than it was when I was a resident, when you were a resident, and so we want to leverage this technology to be able to make ourselves better as physicians, but ultimately to get better outcomes for our patients. Our patients do better when we learn from each other. There's no question.
Of course. Yeah, certainly video is the right way of doing it. I started off more than 20 years ago writing a monthly column in Ocular Surgery News called Back to Basics. I still write it. I'm literally on year 20 of it. But I just can't help but think the readership has kind of fallen off. Because back in the day, 20 years ago, the Ocular Surgery News was a very thick journal that came. And now it's like super thin. So there's not obviously much content. And then even in the columns that like I'm in the issue, my staff just throws it away. Doesn't even hit my desk because we're so digital now. Same way, I used to read car magazines. I don't get any car magazines. Everything I need is on my phone or on my iPad.
Exactly. I mean, the newspapers are facing the same challenge. So yeah, no, I mean, look, the way that we consume knowledge is digital. That's just how it is, and until the next the next big thing comes along, that's how it's going to be. And so look, if those people who kind of lean into it and embrace that and look at all the positive that can come from that, I think that they can really take advantage of the lessons and the learning. And it's also, what's great about it is that, as you said, it's on your phone, right? So you may not have time first thing in the morning, perhaps. Maybe you've got to get your kids ready for school, or you got to get yourself ready for work, or whatever it may be. But there's always those small periods in the day where there's you're just sort of waiting for something to happen. And you just open up your phone, you're ready to go. You can't carry around magazines and newspapers and things like that. It's just not feasible. But with digital technology, it really is personalized for whenever you wanna consume. It's there.
Yeah, we live in an amazing time. Now, I want to switch gears and talk briefly. You did something unusual, which is a mid-career MBA. Tell me about that. What's the reason behind it? Tell me about the whole process.
Yeah, it's true. I mean, look, most people who are MD, MBAs, usually they do that as part of their medical school, right? A combined degree program. And just to give you a little bit more background for my education, I was an English and bio major, so I never took any like business or econ classes. My father's a dentist, and he's a small business owner, as a dentist, but not really anybody in my family who's really in the business world. And as I'm sure you know, it's a different language altogether. And the concepts, the way of thinking is different. So I got interested in business actually through a partnership that we did at Harbor with Toyota. So Toyota used to have a manufacturing plant in Torrance, which is in the same city where Harbor UCLA is. And this was maybe a couple of years, 2-3 years after I took over as chief, and I was looking for ways that we could improve the efficiency of the clinic, because there's a lot of patients who are waiting to get seen in the clinic, waiting for surgery, and I just didn't feel like we were adequately meeting the demand. And patients were going blind waiting. This is a serious matter. And so I was trying to do it on my own, and some of the hospital leadership was aware of what I was trying to do. And as it turns out, the CEO of the hospital at the time had previously been at California Pacific Medical Center in the Bay Area, California. And he had worked with Toyota, where they had, there's the what's called the Toyota production system. You may be familiar with it. It's sort of the basis of, lean systems and Six Sigma and a variety of different operational optimization strategies. And the Toyota production system is sort of like one of the first to have been developed. That's the reason why Toyota developed into being such an automotive giant, is because their operations were so much more efficient. And so he had worked with them in that hospital, and obviously they had a factory right in our own backyard, and said, like, look, would you be interested in doing a philanthropic project with a division in our hospital? And they were very interested in doing that. So it came down to a few different divisions who expressed interest, and they were interested in working, and they ended up choosing ophthalmology. And I think part of that is because, saving sight is it's something anybody can understand, right? It's not like, you're working with phlebotomy. It doesn't kind of carry the same gravitas, right? Not that what they do is not important, but it was just a little bit more appealing to them from a PR perspective. So they worked with us, and I have to say I was blown away by the impact that their collaboration had on our clinic. Little things here and there that they would change, and cultural changes that they helped to instill. The whole mentality of how we approach patient care, just sort of breaking out of the way things have been done for the past 10 or 15 years and really thinking new. How would you want this to be? What is the most efficient, most sort of common sense way of approaching this, rather than just kind of doing things the way that they've always been done? And in the county system, in any sort of government agency, you can imagine there's a lot of stagnation, right? Because people just sort of, they fall into a routine and they do things the same way. That's no fault of the individual. It's just kind of how the system is. Anyways, my mind was blown, and I thought to myself, gosh, I really feel like this is an area that I don't know anything about, and I'd like to learn more, because I think that this could help my patients. It could help my career. There's a variety of different reasons that I wanted to do it. So fortunately at UCLA, the Anderson School of Management has a fully employed MBA program. So I looked into it. The dean's office there was incredibly supportive. And there was a program that I was going to be able to do where I spent one or two nights per week, and then one full weekend per month. And the rest of it was done online. And so that worked with my schedule. It was a little tough. My wife was pretty upset because we had a 7-month-old when I first started the program. And she was tremendously supportive, and we got through it. It was actually a 3-year program. It's now been shortened, but a 3-year program, because it's sort of divided based on that schedule. And I learned a lot, and I, a lot of people go to go to business school. Not a lot of people go to business school because they necessarily need to learn the nuts and bolts of the language of business, right? Many of my classmates had already been business or econ majors, and were just kind of using this as a way to sort of take the next step in their professional careers. But what I think most people who go to business school will tell you, it's the people. Going back to what I said about going into ophthalmology, it's the people that really drew me to the field. Well, in going to business school, it's really about the network that you're able to connect with, and the people that you're able to learn from. And some of my business school classmates, I'm still very close friends with them to this day. I'm a business partner with one of my classmates from business school, and so it was a great experience. I think anybody who's thinking about doing it, it's not something to just sort of jump into, because it's a significant time commitment. But if you have a clear idea of what you want to achieve, for me, it was, I really wanted to learn more about operations and how to improve operational efficiency. That and I learned a lot more along the way. I took amazing classes in real estate and all sorts of different things that have benefited me. But I think for people who are thinking about business school, they should really have a clear idea of why they want to do it. And if you have a good idea of why you want to do it, I say do it. Life is short, and there's a lot of things that can be taken away from us. We're in the midst of the LA fires. Right now, a lot of people have lost a lot in terms of physical assets. People have lost their lives, of course, which is very sad. But one thing that my father would always tell me is keep learning, because you can lose everything that you own, but you can't lose your knowledge.
Right.
And so that's how I feel. If you're interested in doing it, you have a clear idea of why you want to do it, go do it. You won't be sad that you learned something new.
It sounds amazing. What were some of the principles that you learned from Toyota to help make the eye clinic at that big county facility more efficient?
Yeah, so I think that one of the things is understanding where bottlenecks arise in clinics, right?
Mhm.
So, for example, let's just say you've got a very basic clinic, right? You've got somebody who's helping check in patients. You've got a workup station where the patients are getting their vision checked and they're getting dilated. And you've got the doctors who are seeing the patients, and then that's the end of the patient's journey. If you're finding that the bottleneck of that clinic is with the doctors, meaning the doctors either aren't seeing patients fast enough, or there aren't enough doctors to meet the demand for all the patients that are there, it makes no sense for you to look at ways you shouldn't be hiring more people to check in patients at the front desk. Shouldn't be hiring more nursing staff to work up patients. You got to focus on that bottleneck, right? And then once you've focused on that bottleneck, you've identified all the different reasons why maybe that step in the operational chain is weak. What you'll find is, okay, maybe you fix that problem, all of a sudden you find another bottleneck, right? Most clinics are actually far more complex than what I've just described. There's multiple steps along the way. So it's a process of continuous improvement. It's like you don't just fix one thing and then you're done. You fix it, you monitor it, you find the next bottleneck, and then you keep working on those bottlenecks. And over time, what happens is the overall efficiency of the system improves. And you can see more patients, you can do it better, patients are not waiting around as long. And so everybody benefits.
So what were some of the changes you were able to, accomplish then? So did you have like X% more throughput in the clinic, X% more surgery? What were you actually able to achieve with all this? And how long
Yes.
did it take? How many years?
Yeah, so you mentioned that we have tremendous resources in the county system, but those don't come just because you ask for it, right? You have to prove a need for those resources. And so one of the things that we tried to do was to be very evidence-based about our asks of administration, right? So we had data to show, like, look, our residents are spending too much time involved in surgical scheduling, taking care of paperwork to schedule patients. Their time is far more valuable spending time with patients, right? Not dealing with paperwork and surgical scheduling and preoperative clearances and all those types of things. So would you support us in hiring a nurse practitioner? Actually, it turns out they hired 2 nurse practitioners for us. So then the surgical scheduling, all that whole piece of getting a patient to the operating room, all of a sudden that was taken over by somebody else, and then the next patient could be seen, right?
Yeah.
So that's just one example, and we changed around a couple of little things about how our patients were flowing through our clinic. So we didn't want them coming in, getting their vision checked, then going back out to the waiting room, then coming in and then getting dilated and then going back out and then coming in, getting seen. Like this back and forth is very inefficient. It creates a lot of, you want a healthcare space to be therapeutic. It should be calm, right?
Mhm.
And that's not conducive to a therapeutic environment. So we tried to change our flow so that we're only bringing patients in from the waiting room when we have the capacity to actually take them all the way through. And so we came up with a very simple but effective way of visualizing that. So every patient had, for example, a box, and that their chart was put in. This is when we had charts. The chart was put in that box, and then the box had different orientation. So if the box was up, that means that the nursing staff had to do something. If the box was another orientation, the physicians knew they had to do something. And so from a manager's perspective, you could walk in and you could see what was going on in the clinic immediately. It's all visible. And that's actually Toyota production system. That's how their production system works. You can actually flags go up when steps in the operation chain break down. So those can be addressed right away. So if it turns out that there's a lot of patients who are waiting for workup, we don't have enough patients. We have pretty soon the physicians aren't going to have enough patients to see. Well, and we've got a lot of patients who are waiting to get worked up. Well, we have to divert our resources to get those patients worked up so that the physicians aren't sitting there with nothing to do, nobody to take care of. Those types of things.
Well, I think one important thing you brought up is once you fix one bottleneck, you have to reanalyze it, because now where's the next issue? Because that has some other upstream or downstream effects.
Absolutely, it's never done. The project is never done, and so it takes people who understand that. That was part of the education, is for people to understand that it's not like there's no silver bullet. Most problems,
Mhm.
most complex problems, it's not. If it was easy, it would have been done already, right? I mean, let's be honest, it's complex, and
Yeah.
so and it's constantly evolving, and so you have to be nimble, especially a county hospital harbors a level 1 trauma center, so it's not just the scheduled patients, it's the 20 or 30 emergency patients who are coming in through the emergency room. How do we accommodate them? How do we take care of
Right.
urgent matters, but not compromise the care of patients who've got a, they've maybe they're they've taken time off of work. They only have a certain window to be here. We don't want them to leave before they've gotten care, or else, because they have pressures to get back to work. They have to, support themselves and their families, and so we have to be really respectful of the time that patients' time is incredibly valuable. We have to just have to figure out ways to address the emergencies, but also be respectful of patients' time when they're with us.
Right. The other thing I loved was the idea of just delegation, meaning everyone should work at their maximum capacity. You, as the surgeon, you could answer the phone or do the surgery scheduling or even mop the floors. But given your very specialized skill set, perhaps you're best doing surgery or maybe seeing complex consultations or doing lasers or something.
Exactly, and that changes too, right? One of my former fellows just opened up his own practice, and he was kind of doing that. Maybe he wasn't answering the phones and mopping the floors, but he was doing a lot more work beyond just what he learned in fellowship and residency
Right.
in medical school. So, when you're starting out and you're not as busy, to contain costs, it makes sense to take on more of those responsibilities. Actually, it's a good thing, because the more you understand about that work, the better you can manage it. Later on,
Right.
you
Yeah.
have to give it to somebody else. But that changes, of course. He's very busy now. He doesn't do all of that anymore. But at first, it's valuable. It's valuable to understand everything. You don't have to be perfect at everything, just to understand it. It carries a lot of value as a manager.
Right. And then afterwards, as you get busier, just putting together a great team. As you said, the people are everything.
Everything.
That's
Everything.
really that's the key thing. Now, should we be teaching more of these business concepts in med school, residency, fellowship? Because I learned zero of this in med school, residency, nothing. Should we teach this?
The short answer is yes. I think medical education is certainly evolving, and actually, when you and I were both primarily you would have these monthly, quarterly business of ophthalmology meetings, right?
Yeah.
So the types of topics for your listeners, the types of topics that we would have was, you're interested in starting a clinical trials program. Well, what does it take to do that? What are all the steps that you need to start a clinical trials program in your practice? Or some of our residents, they really want to get involved in industry. How can you get involved in industry? What are the steps so that you could be a key opinion leader, speaking on the podium, et cetera, or writing for medical journals, for the general ophthalmology audience? Those types of topics are really valuable. Well, for retina, PE is a huge topic in the business side of
Oh, yeah, private equity. Yeah.
it's a huge topic in retina. And so we had a session where we actually had, you'll remember, we had one doctor come in whose practice had already sold to private equity, two doctors who left their practice because they were about to sell to private equity, and another person who wasn't sure what they were going to do because their practice hadn't decided yet whether they were going to sell to private equity or not. And so we had a really robust discussion about the pros and cons. That's real world. That's real
Right.
world. And that, yes, it doesn't at the end of the day affect the medical decision making. I mean, I guess in some ways it might, right? The practice setting can certainly affect medical decision making to some extent, but it does impact how happy we are in our careers and what's the right fit for us as physicians. And I think more and more doctors who are coming out of training, they're realizing that there isn't just this one path that they can take. There are a lot of different
Right.
ways, a lot of different paths that they can take, and that can evolve over time. What was right out of fellowship is maybe the not right 5 or 10 years out of fellowship or residency. And so yeah, I think having that knowledge, I learned a lot from those sessions, and so I think that we should be incorporating more, and I think that there has been a concerted effort to include more real-world business principles in medical education. Certainly in our fellowship program, we've tried to do that, having some of our alumni who've been out in the real world to come back and then
Sure.
kind of share their real-world experiences with our trainees is really beneficial.
I mean, there's so many great topics, the ones you mentioned, but also like, let's talk about marketing. Let's talk about surgery centers. How do you get involved in a surgery center? How can you become a partner in a surgery center? What are the regulations involved there? We talked about, contract negotiations. I flew in an MD-JD, Lisa Nijim, who was on our podcast previously, who talked all about, well, how do you negotiate the best contract for yourself? What are the various, so there's so many great business topics that I think, wow, maybe we can incorporate some of these in future podcasts.
Absolutely. I've already thought about one, which is actually something that you and your viewers have probably thought about too, is what's the future of office-based surgery in our field? I think you had a video on this topic. And it's extending into retina. There's a handful of retina specialists who are doing office-based surgery. Well, what does that mean? What's required for office-based surgery? Is it safe, first of all? And if it is safe, maybe for this, how do you choose the right patient population for office-based surgery? How does the reimbursement work? If you're taking insurance, can you do office-based surgery that's cash basis? So there's a lot of different questions that I think people have. But I think that's going to be a really big one, because just as ophthalmic surgery sort of transitioned from a hospital-based setting to an ASC-based setting, and that really followed with a shift in reimbursements, I think you'll start to see a shift towards reimbursements for office-based surgery as opposed to ASCs. It's not going to work for everybody. Some patients need to be in an ASC, so just like some patients need to be in a hospital. But for those select patients who would qualify for office-based surgery, that can actually help to decrease costs and make it a lot easier for patients. Patients who have office-based surgery, for example, they don't have to be NPO. They get a lozenge with some with a benzo, and they're good to go. Look, I don't know. I've never done it myself, but I'm intrigued by it, as I'm sure a lot of people are, and they want to learn from people who are doing this. This is a perfect platform for them to be able to do that.
Yeah, I think it's going to slowly evolve, and I think there's certain patients where, I know my own population, there are certain patients where I think, wow, they're such an easygoing patient. When I look at them with the indirect ophthalmoscope, they can just stare into the light. I'm like, that's a good sign, positive sign. That'll be easy for surgery. And then you go to the operating room, and you're like, ask the anesthesiologist, what'd you give him? And she says, 0.5 milligram, 1 milligram per set. I'm like, that's almost nothing. We could have done that in my clinic, especially with topical anesthesia. But then again, there are, as you said, some patients where, those patients 90 plus had a lot of medical problems, or the patients were real squirrely and really very nervous, want to be out of it. They can get a whopping dose from my anesthesiologist. So yeah, there is a balance there, but I think it's going to get more and more popular as time goes on. I'm not doing it yet.
Yeah, and look, and not a lot of people are in the retina space, but I know a lot of my colleagues and friends who are really interested in learning more, as I am. I met a retina specialist out in the East Coast at the American Retina Forum meeting, which is held by one of my colleagues at UC Irvine, and I learned so much. He had a very brief presentation about his experience, and my interest was piqued immediately, and so. I was sharing those types of experiences, I think, has a lot of value. And, at the end of the day, kind of going back to what we've already said a few times now, is really what's best for the patient. If you have an office-based operating room and you can do it safely for the right patient, and you're maybe facing a dilemma, this patient has a MAC on RD, maybe it's really starting to encroach on their fovea, and you want to be able to intervene right away, but you're worried maybe the patient has to wait until the next day, or you're not even sure if you're going to be able to get OR time.
Right.
Well, being able to deal with it right away has a lot of value. Or maybe an endophthalmitis patient, post-injection endophthalmitis or post-surgical endophthalmitis patient, time is vision. And so the sooner that we can get a patient into the operating room and cleaned out, the better off they're going to be. Again, maybe not going to be perfect for everybody, but for some patients, if we can make a little bit of a positive impact on their outcome, I'm all for it.
Yeah, nice to have the option. That'd be great.
Absolutely.
Well, for our listeners and viewers, if you're listening to this and you think it's a good idea to discuss some business topics, leave a comment below. Leave a comment below of any topics you want to have discussed here. We're happy to do all this. I'm just so looking forward to this RetinaRounds website. This is going to be amazing. The videos, the Podcasts will be coming. Love to learn more business topics. Please, I will subscribe. I encourage all my listeners and viewers, click over and subscribe as well.
Thanks so much, Uday. Appreciate you having me on today.
Oh, this is fantastic. So remember, listeners and viewers, of course, got a new Cataract Coach video every day, but now we have a new RetinaRounds video every single day. New Cataract Coach podcast every week, and we're going to have a RetinaRounds podcast too with flavors of business topics too. More to come. You will love it. I promise. Check it out. And until next time, I'll catch you later.